Welcome to our final explainer in this vestibular physician-focused series on enlarged vestibular aqueduct. Over the course of this series, we've broken down the anatomy, the genetics, and the diagnostic criteria. But today, we're bringing it all together, right into the consulting room to look at the day-to-day clinical reality for these patients. This explainer is based on the literature review Enlarged Vestibular Aqueduct, a vestibular physician's deep review of congenital inner ear pathology, hearing loss, and management, published by Australian Dizziness Clinics.com. Let's shatter a major misconception right off the bat, the idea of an inevitable, uncontrollable decline in these patients. We need a critical paradigm shift here, because most acute hearing losses in EVA are not just bad luck. They're actually completely avoidable events. Think about it. A single clinical conversation with a patient or their parents about helmets, nose blowing, and diving, that can fundamentally change a child's auditory future. As vestibular physicians, our role isn't just to diagnose, it's to actively protect. We'll be moving logically through 4 key areas today: precipitants and prevention, prognosis and natural history, pediatric interventions, and future directions. Starting with Section 1, Precipitants and Prevention, where we shift from passive observation to active intervention. We really need to implement a strict if-then clinical framework in our practice. Because of the third window physiology and pressure instability inherent in EVA, the inner ear is highly vulnerable. In fact, data shows that between 25 to 33% of EVA patients have documented trauma-related sudden hearing loss events. That's a huge chunk. So, if head trauma or contact sports are at risk, then helmets and avoiding high-impact activities are absolutely mandatory. If Valsalva or straining is a risk, well, you've got to counsel against forceful nose blowing. If barotrauma is on the table, scuba diving is pretty much generally contraindicated. Even things like otitis media and heavy physical exertion require prompt treatment and defined limits. Every single patient and their family needs to be educated on this exact risk reduction framework. But what happens when an acute drop does occur despite all these careful precautions? Your immediate response should really be a 2-step process. Step 1, an urgent audiological review to confirm and quantify the drop. Step 2, consider an empirical trial of high-dose systemic corticosteroids. Now, sure, we don't have large-scale randomized controlled trials specifically for EVA, but the established clinical practice, which we extrapolate from sudden sensor neural hearing loss paradigms, is a short course of prednisone. Usually we're talking about 1 milligram per kilogram for about 7 to 10 days. It's a completely reasonable, evidence-backed rescue attempt to try and stabilize that inner ear. Moving on to Section 2, Prognosis and Natural History, focusing on understanding the long-term auditory trajectory. So when a family asks you, what does the future hold? You need to have the data ready.
The absolutely crucial point here is this high-yield data anchor. 75 to 90% of children with EVA are going to show a progressive decline in their hearing over their lifetime. And prospective cohorts actually show that roughly 25 to 50% of patients experience a significant measurable hearing decline over just a 5-year follow-up period. That high likelihood of progression is exactly why early, proactive, preventative counseling is absolutely critical. Remember, you're not just managing their hearing for today. You are literally preserving their baseline for the decades to come.
So what does this progression actually look like in practice? Well, it's usually not a smooth linear slope. While a minority of patients might partially recover after minor threshold shifts, especially if the trigger was a reversible event like a viral illness, the vast majority experience what we call a stepwise decline. Basically, their hearing is stable, then a precipitating event occurs, it drops, and bam, it establishes a new lower baseline. It's also super vital to know that the severity and speed of this progression track very closely with their genetics and anatomy. Patients with biallel SLC26A4 mutations, a greater degree of aqueduct enlargement, or concurrent Mondini dysplasia, they generally face a much more severe and rapid trajectory of hearing loss. Now for Section 3, Pediatric Interventions and the Clinical Pathway. Let's not forget, EVA is principally a pediatric diagnosis, requiring highly specific early interventions. Newborn hearing screening is the absolute catalyst here. Catching that characteristic airborne gap or sensory neural loss early enables timely amplification. Ideally, we want to fit conventional hearing aids within the first year of life. This is paramount for their vital speech and language development. But here's a clinical pearl that is way too often missed. You must also proactively screen for developmental motor delay. In kids, vestibular involvement from EVA rarely looks like that classic acute room-spinning vertigo. Instead, it kind of sneaks up as delayed walking, unsteadiness, or apparent coordination difficulties. You've really got to actively look for this vestibular footprint.
It's great because our entire pediatric pathway integrates into a single, cohesive clinical workflow. It starts right at confirmation with strict 3 to 6 month audiological monitoring, plus that vital preventive counseling we talked about regarding contact sports and diving. If hearing loss is present, we move straight to early hearing aids. If there's an acute drop, we jump to corticosteroids. And if the loss becomes severe to profound, keep in mind that EVA is absolutely not a contraindication for a cochlear implant. In fact, outcomes are highly favorable. Importantly, this pathway also includes formal vestibular rehabilitation through a pediatric physiotherapist if any of those motor delays or balance symptoms are identified. It's really a complete integrated blueprint for care. Finally, let's hit Section 4, Future Directions. We're looking at the horizon of precision vestibular medicine.
So we know that SLC26A4 mutations account for the majority of syndromic cases, right? But what about the rest? Well, research is intensely focused on mapping non-SLC26A4 contributors. We're looking at genes like FOXI1 and KCNJ10 and utilizing genomic stratification to better predict a patient's individual hearing trajectory. By understanding the exact molecular defect, the field is pointing us straight toward a future of mechanism-targeted therapies. Because EVA is largely a monogenic disorder linked to pendrin biology and endolymphocytification, it's a prime, highly attractive target for future genetic and molecular therapies.
But until those gene therapies actually arrive and are proven in human trials, this is the paramount takeaway you need to bring to your clinical practice right now. We cannot cure EVA today, but we can manage it masterfully. Early diagnosis and rigorous prevention remain the highest yield interventions we have at our disposal. You literally have the power to protect these patients' hearing through education, careful monitoring, and a rapid response to acute events.
This leaves us with a pretty provocative thought as we wrap up this deep dive. As researchers rapidly uncover the final pieces of the EVA genetic puzzle, how soon will precision mechanism-targeted therapies completely redefine our intervention timelines? Will we soon be looking at an era where we don't just prevent that stepwise decline, but actually correct the underlying endolymphatic imbalance before the first drop even occurs? Honestly, it's an absolutely thrilling horizon for vestibular medicine. This concludes our 6-part series on Enlarged Vestibular Aqueduct for vestibular physicians. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. And please subscribe to the channel and leave a rating to support the series.